Good evening. I'll start over again. Thank you so much for the invitation. It's a privilege to be here. Just to pick up on some of the things that Kimberly was talking about in terms of eligibility criteria. I know today's speaker session is on physician-assisted dying. I think one of the criteria that you probably picked up on is capacity and consent. And if I think about my experience, so my background, I've been in practice for 7 years. I've taken care of people with advanced dementia. I've assisted in them trying to live well during the last days, 2 weeks, or months of their life, and I've tried to help provide some care to their caregivers as well. And if I think about all of those experiences, whether I was taking care of somebody in their home, whether I was taking care of, for the majority of the time I practice is in hospital, in every single case, those patients would not have been eligible for medical assistance in dying as we know it. If I think about, did I help them, so as a palliative care physician, before medical assistance in dying was legal, or even now, so what was my role in to try to assist them? And so I think so when I thought about what types of words I could share, what type of conversation I could have today with the audience, I thought maybe if I highlighted what does living and dying with advanced dementia look like. So if I think back to all the people that I've been involved with their care, so just thinking in the last couple of months, everyone I've taken care of has had a profound change in who they are in the last year that they've been living. There's been cognitive changes, so changes in their ability to interact with their family, changes in their ability to talk with their family. There's been significant physical changes. So as the gentleman pictured here, so I can think of one gentleman who was diagnosed with fairly rapidly advanced frontotemporal dementia. I met him a few months ago, and he went from driving his car, living an independent post-retirement life, to being in bed, not able to communicate with words with his family members or with the medical staff, not being capable for his decision-making, and we were, by the time palliative care was introduced, we were having to think about, so in this context, in his context, for him, how do we provide him care? Another person that I can think of, so that's, as we know that, dementia alters people's lives, alters the lives of families, but everyone's individual experience is unique. The experience might be as, we'll call him John. John's experience with dementia was a year. Another patient I had, Marta, she lived with dementia so John has since died. I'll go back to John. Marta, who I met a few months ago, she lived with dementia for 6 years. It was a different type of dementia. Still can't hear? Okay, I'm sorry. Thank you. I'll speak louder. Sorry, I'm a little... when they recruit palliative care physicians, they make sure they're soft-spoken. So they've weeded out all the loud, aggressive palliative care physicians. Is that better? Sorry. Thank you. So I was just trying to share the variability in living and dying with dementia. So I talked a little bit about John, who unfortunately went from living a fairly independent life to being physically bedbound and incapable of communicating with his loved ones within a year from a frontotemporal dementia. Marta is another woman that I met a month ago, roughly, and she had lived with dementia for 9 years. It was a vascular dementia, and her course was very variable. And so and I don't have to tell the people in the room, like, it's just, so are there guideposts? Like, although dementia affects people in different ways and everyone's experience is unique, I think if I were to meet Marta and John a year before they died, what did I wish that they knew if they were capable of understanding? What did I wish their families knew? I hope that they knew that eventually, a lot of people die of dementia, and if they were to die of dementia, the last year of their life would be marked by changes in their ability to communicate, speak, and changes in physical functioning such that they would be dependent on all of their care. And I think that's important because when it comes to trying to define how do you live well, so common questions I get asked, so although I wasn't able to talk to John about this, or Marta, I wasn't able to talk to her about this, what I talked to their family members about was, given the way they were living right now, what mattered most? Now, I was talking to John's wife, and John's wife said, well, John's still there. John's still there. I can talk to him. He's still enjoying food. So what matters is, comfort. So John's wife, like 90% of caregivers, said that comfort was the most important goal for her loved one as he was living and dying with dementia. But what did comfort mean for John? It was enjoying food, interacting with her, and she saw that, you know, when John was awake, like, she saw joy, and she felt he was experiencing joy. So although comfort is 90% of the goal, what comfort means needs to be individualized. In Marta's case, what was most important as I met her, so I took care of John for 2 months before he died. For Marta, I was only involved in her care and her family's care for 3 days. And what they said what mattered most was, so Marta had, just like John, she had lost the ability to talk to her family. She had experienced decline over 3 months. She had repeated infections, and she was not able to eat anymore. And they felt that family, she always was very family-centered, family mattered most. And what they were hoping was that there was a birthday celebration for one of her grandchildren that was going to be held at her home, and they felt that care, you know, she's family-oriented. We think she's still awake at times during the day. We think she'd want to be part of the birthday, and she's interacting with us, she's squeezing our hand. So taking my cues from the family, it was comfort meant for her, you know, directing medical care. So is there a possible way we could help her be a part of that birthday celebration? So in general, these are the things that matter to people: living longer, increased comfort, improved function. And I think for the on the flip side of things, there are certain things that are known for, you know, in cases of Sue Rodriguez, which we heard about, Carter, what are the things that make life not worth living? So there's things that make life valuable. And the 3 commonest reasons, if you look at data from Oregon, for why people want medical assisted dying, euthanasia, or physician-assisted suicide, physician-assisted death, is that if they find that they've lost meaning in who they are, they lost their self-worth, their dignity, autonomy, they view their life as an existence but not truly living. So I think these conversations, every single, as I said, you know, I've taken care of people in their last days, 2 weeks, and months of life, and I unfortunately have not had the chance to talk to the person with dementia. It's always been with their family members. So I think the way physician-assisted suicide, it keeps coming up, physician-assisted death looks like right now is trying to help caregivers determine what's most important to their loved one. If they could speak, what would they want in the here, now, and in the future? What are their values? And then trying to tailor their medical care so that we're actually shaping their care in accordance to the values. So that's what living and dying with dementia looks like currently. If you're looking for tools like, and I think some of the principles, when most people think about palliative care, a little bit of a segue, I think most people think about death, dying. Why did I go into palliative care? It's not because I have this, you know, I view it as a field that's, so good dementia care. If you're caring for somebody with, whether it's advanced dementia or chronic dementia, what you're trying to do is, in a time that they might be losing control over certain functions, you're trying to increase the control that they have over their life. You're trying to improve their function. You're trying to provide patient-centered or person-centered care, family-centered care. Those same ideals that are part of good dementia care are part of palliative care. It's just that when most people think about it, palliative care should only be reserved for people who are imminently dying. And I think that's, if I could go back and meet John when he was recently diagnosed, or meet his family, or Marta, what I would want to engage them is conversations right up front about what matters most, what their values are, and give them a view of, if they're interested in talking about the future, what does the last few months to weeks of life with dementia look like, and do their values change? Are there states of living that would be worse than dying? And the reason why I put up that slide is the Speak Up. If you Google Speak Up is it's a website that helps caregivers, families, and physicians engage in advanced care conversations. There's just sort of conversation starters. So you can have, there's useful phrases, but it goes up to, for people, there's actually a work plan in which you could, have in writing, like, what's most important to me. If I all of a sudden lost my ability to think, talk, and walk, and that was incurable, what type of care would I want? Would I want to focus on care that helps me live as long as possible? Or are there some things that are more important than living as long as possible, right? And if there are things that are more important than living as long as possible, what are they? What do they mean to me? So that's quite, I think that's the cornerstone of good palliative care for dementia, which is advanced care planning. If I have time, I'm going to look at Susan. I just wanted to go over two common medical scenarios that happened in the last year, months to weeks of living with dementia. And those two scenarios are everyone I've taken care of with advanced dementia has experienced feeding problems, whether it's a loss of appetite, loss of interest in food, unable to swallow food. And if I was a medical student now, what I'd be learning, and if I was a physician now, what I'd be learning, is that contrary to intuition, so if somebody has feeding problems and they're losing weight, I would think that if I could boost their calories, even if it meant artificial feeding through a gastrovaginal tube, that should probably help them get stronger, gain weight, live longer, feel better. It would make sense to me, versus trying to just give them textures of food or tastes of food that they enjoy and even forgetting about the calories. So although intuitively it might make sense to boost someone's calorie at that stage, if somebody's in the advanced state of dementia, which is unfortunately they're not able to get out of bed and they're only able to communicate with very few words, and that's been going on because of their advanced dementia, then what science is telling us right now is that tube feeding actually does not improve survival, does not improve function, does not decrease aspiration events, and actually doesn't heal complications of dementia such as pressure ulcers. So because of this new evidence, 50% of people in the United States, there's actually been a decrease in GJ tube insertions in people who are, let's say, are living in a long-term care facility because of this new knowledge about the benefits and risks of feeding versus artificial feeding versus hand feeding. So that's another thing that I wish John and Marta knew earlier on, because I think, so in John's case, I think if John had known that, and he had had a conversation with his wife about that, the stress that she underwent as multiple physicians, nurses who she hadn't met, were like basically every 2 days, so what are we doing with the fluids, you know? Are we still continuing the fluids? And her distress would have been a lot less, and I think there would have been a clearer idea of what John's values were. A second complication is that the majority of people, so how do people actually die? What is the usual mechanism? It's hard to predict, but the most common way that people with advanced dementia die is through some sort of infection, whether it's a pneumonia or whether it's a urine infection. And because people usually aren't able to tell us their experience, so if you have a pneumonia, are you in pain? How is it affecting your quality of life? It's really hard to tell. But a recent study, by recent I mean about 10 years ago, people with advanced dementia, such as that I've described, were 300 people were followed, and what was looked at is people who received antibiotics for infections and people who didn't receive antibiotics. And the group that received antibiotics lived longer, on average months longer. So I think it was over 200 days longer if infections were treated with antibiotics. But if you ask their caregivers or if you ask the nurses taking care of them, they actually had a lower perceived quality of life than the people who didn't receive antibiotics. So going back to Marta, the decision we made is Marta, I only took care of her for 3 days because she actually did have a pneumonia and an infection. And going back to her values, she valued comfort. Comfort was spending time with her family. She was dehydrated when I assessed her, so before the birthday, she did receive IV fluids. But when her breathing rate increased from breathing like you and I are right now to over 20 breaths a minute, and she started to sleep more, and clinically putting a stethoscope to her chest, it looked like she had a pneumonia. Because she didn't value, according to the other goals that I was talking about, function, comfort, living longer, in her current state, living longer wasn't important to her. The family was very clear that that was her expressed wish in the past. And so we were able to provide comfort care, which did not include antibiotics because that was not within her goals. So that's, I hope that's been helpful in the sense of just providing a bit of my experience and what palliative care currently looks like for people with advanced dementia. Thank you.